the last set of disclosures. We are grateful to have partnered with Children's Minnesota to offer 4 AMA PRA Category 1 credits for physicians and 4 ANC nursing contact hours. Please take a moment and review the additional accreditation information from Children's Minnesota on the slide. Next, we have our standard disclaimers and confidentiality protection statements to share from Children's Minnesota. And lastly, we have our standard faculty disclosure announcement. Our planning committee and presenters have no relevant financial relationships to disclose. Please ask us if you have any questions about these disclaimers, disclosures, and/or accreditation information. For our final presentation, we are joined by Dr. Ann Runkle. Ann Runkle is an assistant professor, of emergency medicine and pediatrics at The Ohio State University Medical Center and Nationwide Children's Hospital. She is the associate director of the Ohio EMS for Children State Partnership Program and a member of the National EMSC EIIC Pediatric Pre-Hospital Readiness Steering Committee. Her academic interests include pediatric readiness and community EDs and the pre-hospital environment, and improving the quality of care for critically ill children. We are very excited for her presentation, Pediatric Respiratory Emergencies. She will address the following objectives shown on the screen. Thank you so much. Dr. Runkle, take it away.
Awesome. Thank you so much for the introduction. And while I'm currently in Ohio, I am a Minnesota transplant. So I appreciate you all hosting this and the collaboration. I'm just going to start sharing my screen. And there we go. Oh, I'm just going to make sure I'm sharing my sound as well. 1 second. Great. So, hi everyone. I am going to talk about Peds respiratory emergencies tonight. I live half in the Peds world and half in the general EM world. So I spend about half of my time in non-pediatric EDs. And I think there's some differences in those environments that we can kind of use some of our pediatric emergency protocols and guidelines to care for the children that we see in our general EDs very capably. So this is going to be a timely talk because it's respiratory season. If your ED is anything like our EDs in Ohio, you already have the music of the night, which is the wheezing you hear from every single room. So we wanted to go through a couple of different items to take care of all of these children well over the next few months until we make it through to the spring. So the first thing we're going to talk about is differentiating between respiratory distress and respiratory failure. The next thing we're going to talk about is some of our pediatric respiratory interventions and how to optimize them. So talking about nebulized meds, high flow nasal cannula, and suctioning. Next, we're going to talk about stabilizing critically ill respiratory patients prior to transferring them out. And then last, we're going to talk about some resources for standardizing care for kids in your ED. So there's a lot of resources for standardizing care for bronchiolitis, croup, and pneumonia. And if your hospital doesn't have a pathway, or your local children's hospital doesn't have a pathway that's public, there's a lot of resources you can connect with to standardize how you care for those kids in your ED and kind of take a lot of the guesswork or variation in practice out of it. So I'm going to talk at the beginning about the Peds assessment triangle, which I'm so glad that Kirk brought up, because this is the best way you can get a gut feeling for how a kid looks when they come into your ED. So this was originally developed in 2000 for pre-hospital providers, but is also used and has been validated by triage nurses. And it really has been proven to give you a good sense of, does a kid look sick or does a kid look well? And then the next best thing it does is say, why, if they look sick, why do they look sick? So the 3 arms of the Peds assessment triangle are appearance, work of breathing, and circulation. So starting with appearance, because it's Peds, we have to have a ridiculous acronym. So it's TICKLES. So for appearance, the things you're looking at are tone, interactiveness, consolability, look or gaze, and speech cry. So what does that mean? Tone, is the kid limp or not limp? If the kid is limp, that's concerning. Interactiveness and look gaze, I kind of put together. The big thing to me is if the kid has a 1,000-yard stare or not paying attention to you, that's concerning. For example, in a neonate, that could be a sign that they're in like subclinical status epilepticus, they're having seizures, and the only sign is that they're not interacting and they're staring off into the distance. Consolability, I expect most kids in the ED to be angry. I'm worried if they're not, but generally they're able to be calmed by their parents. And then speech cry, generally, like for an older kid, how are they talking to me? Are they talking in 2-word sentences or normally? But also crying, like I think we can all differentiate between normal angry baby crying and a high-pitched cry or whimper that jumps out to you as concerning. So this kid on the right, they're not interacting. This kid's eyes are closed. They're not interacting with you at all. They look unhappy, but they can't tell you what's going on. This is a kid whose appearance is off. So the next thing is work of breathing. So we'll go through all of the things that kind of go into your work of breathing assessment. Respiratory rate, I've done peds for years now and I never remember this table. So I think the best thing, especially in triage, is just having normal peds vital signs up on your walls. But generally it's going to be infants can breathe up to 50 times a minute, toddlers, preschool kids kind of up to 30, and then school age and adolescents, you really should be getting down towards normal adult respiratory rates. Positioning, the big thing for work of breathing we often see is the tripod position. So if a kid is naturally kind of sitting up and forward like this, it optimizes their muscles, like their accessory muscle use, and it also allows for improved expansion of the diaphragm. So if a kid is sitting forward and breathing like this, I'm concerned. Another thing we'll look for in work of breathing is retractions and nasal flaring. And I'm going to link to this resource at the end. A lot of these videos are from the Open Pediatrics video series, which is a really fantastic video series if you want to do PEDS education for your ED. So retractions, this kid has all of the retractions. So they have the subcostal breathing, so that belly breathing you see at the bottom. As you work your way up, you see they have intercostal retractions, so they're retracting in between the ribs. They have suprasternal retraction, so all the way up there in the notch, they're retracting in. And then as you keep going up, you're seeing they're also nasal flaring. So that is basically their body is trying to increase the space in their upper airway by flaring out with every breath. And this kid is working so hard that they're also head bobbing. So that with every single breath, their head is moving up and down. So this is severe respiratory distress. It's not shown in this video, but some young infants can even have sternal retractions. So you see their entire sternum collapsing down with each respiration. We'll get to it later, but this kid's also starting to look a little bit sweaty and they're not opening their eyes. Grunting, so you might need to turn up your sound for this, but I'm gonna play some clips of this and just so you can hear it. I'm going to play that one again. Let's see. So grunting, it's an expiratory noise. It almost sounds like a squeak. And basically what that is, it's usually seen in infants, and it's them exhaling against a closed glottis. And basically what they're trying to do is give themselves PEEP to stent open their airways. And grunting can be tricky because especially in kind of younger infants, you're like, is that crying or whimpering or is it grunting? For me, grunting is a 5-alarm fire. So if you are worried at all that the noise the kid is making is grunting, this is a kid who should be roomed immediately if possible. Other abnormal noises we can hear, stridor. So I'm going to play this clip really quickly. So kind of sounds like whale noises. It can be both inspiratory and expiratory. We see inspiratory most commonly, but it's a high-pitched noise that almost sounds like whistling that is indicative of upper airway narrowing or obstruction. So in the winter, we see it most commonly with croup. Usually it's just inspiratory. If you get to both inspiratory and expiratory stridor, usually, depending if you have a foreign body, it can kind of indicate where it is, but it could mean that you're at the point of severe obstruction. Wheezing, the last sound. So there, it's basically a high-pitched noise that you're going to hear in the lower airways. So generally, this is going to be indicative of a lower airway obstruction. The sound I played was expiratory wheezing, but you can have both inspiratory and expiratory wheezing on your assessment. So once you've assessed your work of breathing, the best thing the pediatric assessment triangle can tell you is, how do you figure out if this kid is in respiratory distress, respiratory failure, or cardiorespiratory failure? So if you take a look at these diagrams, if it's only the work of breathing that's knocked out, that kid's just in respiratory distress. Like we see that a lot with bronchiolitis, where you have an infant that's retracting away, breathing like 70 a minute, but they're smiling, they're reaching for their bottle. That kid is respiratory distress, or even may just be stable depending on how severe their work of breathing is. For the child who has abnormal work of breathing and then also has an abnormal appearance, so they're keeping their eyes closed, they're not interacting with you, they have kind of a weak cry, that is respiratory failure. So work of breathing and appearance are both out. And where we get really concerned is cardiorespiratory failure, because this is a progression. Your respiratory distress leads to respiratory failure, which is shortly followed by cardiorespiratory failure. And that is when your circulation starts to fail. So first, we'll just see respiratory failure. So this is an example of the progression from respiratory distress to respiratory failure. And what you'll see here, this kid has some perioral cyanosis, which is a late finding. But basically what you're having is you're having inadequate oxygenation or ventilation. And so you don't just have respiratory distress, you also have your appearance is abnormal. So this kid is sweaty, they have their eyes closed, and they look pretty limp. They're not moving around. All of their body's energy is going into breathing. So, with an adult, when they have a COPD exacerbation and they're hypercarbic, they will start to get altered. They tell you they're about to die. They'll tell you they can't breathe. Your kid is just going to sit there and either stare off into the distance or be inconsolable or be limp and start sweating. That is respiratory failure. Where we get into cardiorespiratory failure or like cardiorespiratory collapse is when your circulation goes out too. So that, again, is just looking at the kid. It's not measuring cap refill. It's not doing anything else. It's just saying, is this kid extremely pale? Are they mottled? So like, again, in infants, if their hands and extremities are a little bit mottled, that can be normal, but it's not normal in older kids. Or are they cyanotic? If those things are out, you are in cardiorespiratory failure and you are cardiac arrest is imminent. So this is an example of a kid in cardiorespiratory failure. So this kid is actually having a slower respiratory rate. They have bradycardia, they're limp, they may be unresponsive. So again, this is a kid who, if you look just at their respiratory rate, you might say, wow, this is a normal respiratory rate. But if you look at the whole picture and you say, this kid is limp, they are unresponsive, they have cyanosis, you put together the picture of this kid is peri-arrest. So a kid who is in either respiratory failure or cardiorespiratory failure, what you're going to end up needing to do pretty immediately is help them breathe. Because what put them down this whole pathway was them not being able to oxygenate, not being able to ventilate. So this is the point where you need to help them. And if you can correct those two things, you may bring them back from the brink. Because if they arrest, it's your epinephrine, your compressions are not going to be what helps them. It's going to be restoring that oxygenation. So A common mistake we see for bag valve BVM ventilating kids is choosing the right size mask. So on the left, we have the correct size, so it fits over the nasal bridge and down below the mouth to rest on the chin. What we'll often see is sizes that are too small, where it goes over the nasal bridge, but then cuts off on the mouth and isn't resting on the chin. So you're not delivering effective breaths. Other mistakes I have definitely made while ventilating children is first the mistake on the left. So you put the mask on their face and you kind of smush their nose. Since their noses are so small and flexible, basically you completely cut off their nostrils and you aren't effectively delivering your ventilations. So try to avoid completely occluding the nostrils. The other thing I've done is on the right, where basically what you do is you smash the mask onto the face. And what you do is in that process, you kind of flex their neck down. So you're occluding their airway. And again, you're not going to give as effective of ventilations. Another one that's not listed here, but we'll do commonly is especially for babies. Like if you have your normal grip, like a CE grip on your mask, where I put my hands for an adult, it lands on the angle of the mandible. If you do the same thing for a baby, you basically cut off their airway if your hand is on the front of their neck. So just being really careful, especially for babies, that your hand is only on the mandible to avoid kind of collapsing their airway from the front. Other things, common mistakes that we have all made are flexing the kid's neck forward too much or extending it too much just because they have just such small, flexible tracheas. In kids, if at all possible, if you have the resources, getting a two-hand technique is really amazing and is going to get you your best seal. So these are good examples of a two-hand technique in a baby and a toddler. And what the two-hand technique allows you to do is do a jaw thrust to lift the mandible up into the mask instead of smashing the mask down onto the face. And then you're also able to hold the neck in a neutral position so that you're not hyperextending or hyperflexing. So what we'll do next after talking about kind of initial steps and assessment is go into some cases. So the first case is difficulty breathing. You've probably seen this already this winter. So you have a mom who runs in with her 6-week-old infant that looks like the baby on the right. Actually, that looks like a little bit of an older infant, but we can pretend. So the airway's patent, there's no stridor. Your breathing is as seen in the video. So the kid's a little bit sweaty. They have retractions all the way up their tachypnic. They've got nasal flaring and head bobbing. And their extremities are warm and their capillary refill is about 3 seconds. So if you do your PEDS assessment triangle for this kid, what you'd say is, okay, let's look at work of breathing. This kid's work of breathing is abnormal. If we look at appearance, this kid's appearance is also abnormal. They're not interactive. They're a little bit sweaty. Their eyes are closed. So this, and then circulation right now is okay. So we would say this kid is not in respiratory distress. They're in respiratory failure. So you need to act right now. And the nice thing with kids is they're so able to bounce back that you can pretty immediately correct this kid and send them back to respiratory distress or even stable within about 60 seconds. So if this kid who's presenting like classic bronchiolitis, snot pouring out their nose, that kid shows up in triage, the first thing you can do is either suction them in triage if you have those resources, or get them to a room where you can stabilize them by suctioning. And we're going to go through how do you suction them, how do you get vitals on this infant, and then what kind of oxygen should you give them. So for suctioning, there's a couple different ways. You can use a bulb syringe. That's not going to be as effective. That's going to be better for kids who are not in respiratory distress or failure. The most common one we'll see is the neo sucker. So that is also known as the BBG syringe, which you can see on that top right. And then you can also use flexible suction catheters, but those can cause more nasal trauma. So generally, if available, the suction catheters that we see, like the neosuckers, are the best ones to use. So I'm just going to show a quick video on suctioning technique. Okay, I'm gonna make sure my audio is up.
Or a soft catheter suction. Our most favorite one is the nasal aspirator. Sometimes we call it a BBG or baby booger getter, but this is such a great device because it's non-invasive. It's one size fits all, and you don't have to measure. So we find the agencies that have this device are more likely to suction than agencies that don't have it. So one thing you want to do before you get started is make sure you have all your equipment. You can have saline bullets on hand if you're going to use the nasal aspirator. This is our first line device, what we're going to try first. So this hooks up to the end of your tubing just like any catheter would. And then you want to check your suction pressure. So you're going to turn it on to continuous suction. As you can see, your goal here is to be between 80 and 100. So this is already way too high even without occluding. So you want to dial back your suction pressure to be into this range, okay? You may need a little more just to get it there, okay? And so as you occlude and suction, you want to make sure you're not going into high pressure. Another really important thing is your positioning for these kids. If you are going to be transporting and you're by yourself in the back with your patient, you need to do this before you transport. So you need to have your partner come to help hold your patient to secure them so that you're more successful with this procedure. So what you will do is you have your partner hold their arms up above their head. This is kind of our preferred method when we stabilize them. Not only does this hold their arms, it also holds their head. Another way you could burrito wrap the kid and have your partner hold their head, but we find that this way works really well. Also to note, for PPE, you will see us in the videos just not having any PPE on. Of course, for this type of procedure, this is a cough-inducing procedure. Not only would you have your gown, your gloves, your face shield, you also need to have an N95, as this is a cough-producing procedure, and they're going to aerosolize some droplets that you do not want to get, okay? So as you can see, the baby has secretions. And we have this device. We're going to insert it into their nose, into the nair. We want to get a nice, good seal around the nair, and then we're going to occlude. As we occlude, we want to tap the other nair and suction that, move that around. So as we get all these secretions out. And then you can switch and do the other side, okay? So you can switch, include the nair, tap, tap, get all those secretions out, okay? And really suction these kids. Now, another thing to remember.
I know it's fake mucus, but it still grosses me out without the gloves. Another thing that you'll see people doing here is if they have thick mucus secretions, and I'll link to a video with this at the end, you can actually either put saline in both nostrils and then suction, or you can put saline into one nostril as you're suctioning out the other. So another tricky thing for infants is always getting, and toddlers especially, is getting vital signs that are accurate. So this kid is in respiratory failure. Obviously, you're going to be hooking them up to the monitors. After you suction, you'll be getting vitals that way. But for generally well-appearing kids or kids who are in respiratory distress but not yet respiratory failure, there's some techniques you can do to get good vitals and triage. So generally, like this photo on the left, we'll have you keep them on their caregiver's lap when possible. Distractions and rewards, so bubbles, stickers, whatever you've got, glove balloon turkeys are great. And then generally what we'll do for getting your vitals in order is do your respiratory rate first while you're not touching them, just having them sit on their caregiver's lap and measure for a minute so you get an accurate rate. For the heart rate next, that's another full minute counting because there's enough variability that anything shorter than that will not be accurate. Then generally pulse ox, blood pressure, and temperature kind of in that order, especially because for infants, you're going to be getting a rectal temp, which if you do that first, everything else is going to be inaccurate afterwards. The next thing is for placing oxygen on a child. Again, for a kid in respiratory failure, they're probably not going to fight you too much. But for kids who are in respiratory distress but still have normal mental status, what you can do generally involve their caregiver as much as possible. But what we'll have you do is like place the cannula and secure it before you turn the oxygen on. And that can give them a little bit more time to adjust to it before they really start fighting you. Distraction can be helpful for some kids. For some kids, they're going to hate it so much that they're not distractible at all. And then if you're using high flow nasal cannula, which we'll talk about a little bit more later, the big thing is since there's both the infant and the pediatric cannulas, You just want to make sure that their nostrils are not completely occluded with the cannula and that you're getting frequent vital signs, so every 15 to 30 minutes after you put them on it. So for bronchiolitis, as we head into the winter and the RSV vaccine is not readily available, there's kind of practice guidelines for what we should do and what we should not do. So what we should do, absolutely suctioning. You can see kids come in respiratory failure who are, they're somewhat limp, they're like not interactive at all, they're retracting all the way up and head bobbing. And then after 30 seconds of suction and a little bit of low flow nasal cannula, they are completely a different kid and they're completely stabilized and they're admitted to the floor. So suctioning and oxygen early are absolutely evidence-based practice. We'll get into low flow and high flow a little bit later, but some sort of oxygen for work of breathing, hypoxia, or infants who have apnea, if you even just give them a little bit of stimulation through that low flow cannula, it can be enough to stop their apneic episodes. Some sort of hydration, these kids are breathing so fast that they have increased hydration needs, but a lot of them are in respiratory distress, so they don't want to drink. If they are happily reaching for a bottle, absolutely feed them by mouth. But some kids who are in respiratory distress or failure may require either NG feeds or IV for hydration. And then if they have a fever, treat it. It can definitely decrease their work of breathing if you treat a fever either with like oral ibuprofen or Tylenol, although for this kid, not ibuprofen since they're 6 weeks old, or you could do the rectal Tylenol as well. For the don'ts, albuterol is a don't routinely. Interestingly, last year's triple-demic, there was a lot of rhinoenterovirus that was very responsive to albuterol. So generally, albuterol should not be a routine practice, but it sometimes is worth a trial in sicker kids. Generally, if a kid is 12 months old, like 12 months or older, so between the 12-month and 24-month, and like either everybody in their family has asthma or they have eczema, like eczema allergies, it's absolutely worth a trial of albuterol. If it doesn't make a difference, then you tried it once and you've documented that it didn't make a difference. For younger kids, like it's hard for me to justify trying albuterol under 6 months, but sometimes if they're in that 6 to 12-month range and they have a really prolonged expiratory phase, everybody in the family has asthma, or they're like really sick, it's absolutely fine to do a trial of albuterol. It's not a never thing. It's just not routine, and most kids we should not be. Steroids don't help unless, for example, you determine they're definitely an albuterol responder. Racemic epi and hypertonic saline also don't help, and chest x-rays don't help if we can avoid them. Another nice thing, a nice tool you can have is the bronchiolitis severity score. So if you're not seeing a ton of bronchiolitis, it can be hard to standardize, like, is this a kid with mild bronchiolitis, moderate, or severe? This is an example from the Children's Hospital of Philadelphia pathways. Basically in triage, they just have all their bronchiolitics scored on this pathway, and you can be like, and it can also just be a good like objective measure to fit with your pediatric assessment triangle, where you're like, okay, this baby is breathing 70 times a minute and their mental status is normal, like where are we here? Or you could say, okay, this baby is breathing 60 times a minute and they're almost 2, they have nasal flaring, they're inconsolable, this is severe bronchiolitis. There's several different bronchiolitis scoring systems, but this is an example of a publicly available one. So we're going back to your same patient. So you suctioned the kid out and put them on 2 liters of low flow nasal cannula, and you reassess them. Their cap refill is about 3 to 4 seconds, and mom tells you, oh yes, they have not been interested in drinking for the past 12 hours, and their last wet diaper was about 12 hours ago. Their respiratory rate's still 70. You're noticing intermittent grunting, and they're not interested in feeding. So you can't admit children at your hospital. So you start calling for transfer. And of course, because it's the winter, it is delayed due to weather. So this kid is, for right now, they're in they're like in respiratory distress bordering on failure, and it seems like they are getting dehydrated. So since that kid is stuck with you for now, we're going to need to figure out how to hydrate them. So the next thing to talk about is placing an IV in infants or children's. So especially with babies, our nurses will always start in the hands. Feet can also be good, but mostly avoid the AC and the really chunky kids. Warm packs on the hand can be very helpful. For older toddlers, kind of telling them something about what to expect can be helpful, but that's not going to work for this infant. For infants, what you can do is some sweeties. So there's sugar water to help them with the procedure. In older kids, if we have some time, we'll do a topical numbing agent. And then for kids, a lot of our nurses will swear by like the Wee site or the vein light for finding veins in those little kids. Those are both available for about $130, $150. So it's something that potentially your emergency department could invest in. And then the more nurses you have that are great at ultrasound guided IVs, the more success you're going to have too. And on the right are some examples of holds you can do for IV placement where the parent is helping out. If the parent is, they're like, I can't do this, I can't watch my kid go through this procedure, that's also reasonable you could potentially have a staff member help out, depending on what the parent is comfortable with. Push-pull fluid boluses, I can link a video to this at the end, but these are going to be the best way for getting fluids in fast to a dehydrated kid. So you're going to see on the right-hand side an example of how to do the push-pull boluses. So once you have your IV there, what you're going to do is have your three-way stopcock and an IV fluid bag. And what you'll do is just, for example, say you want to give a 3-kilo kid a 10 cc per kilo bolus, that's 30 cc's. You just pull it up out of the bag and then turn your three-way stopcock off to the bag and onto the patient and just push that in. For babies, what I actually really like is to say the baby's 5 kilos. If you want to do a 10 cc per kilo bolus, you give 5 10 cc flushes. You just give 5 saline flushes to the kid. And usually what we'll do is our nurse or whoever is administering this will just do a tally mark or something on the bed so you can keep track of how many you've given. You can't use pressure bags in infants or children just because you're either going to give them, most likely you're going to give them too much, but in pressure, like for kids greater than 50 kilos, a pressure bag's completely fine to get fluids in quickly. So going back to your kid, of course, you find out that it's the triple-demic again and your Peds hospital is on divert and they'll have a bed in about 12 hours. So you are stuck with this kid for now. And the question is, what do you do? So if that kid is still, you have them on low flow nasal cannula, they're still breathing about 70, occasionally grunting, the question becomes, what do you do next? So like back in the day, they would just intubate the kids if they were worried about worsening respiratory failure. Now we actually have the option of high flow nasal cannula. So usually the most criteria like that will vary depending on what your center is, but usually they'll say it's your kid is in respiratory distress and you have one of these things. So they're still hypoxic on low flow nasal cannula. They still have a respiratory rate that's above 70. So and for a while, not, coming and going for greater than 5 minutes, or they have altered mental status, grunting, or apnea. Any of those are good reasons to start a kid on high flow. And your protocol will depend on what your children's hospital does or what pathways your ED would like to adopt. But it's usually 1.5 to 2 liters per kilo for your high flow rate, and then kind of adjusting your FiO2 to the patient's oxygen level. The other thing is if you have this kid for 12 hours, how are you getting them fluids? So feeding, if they're on low flow nasal cannula, absolutely feed them if they are willing to take a bottle. If not, your options are IV or NG. The NG can be nice if the kid's dehydrated and you can't get an IV on them. And then the other thing for high flow, a lot like the CHOP, like Children's Hospital of Philadelphia, for example, they feed their kids on high flow as long as their kids do not still have severe work of breathing. The worry would always be if they're on high flow and they're not doing well, you don't want them feeding and aspirating or feeding right before you're about to intubate them. But this is it's something definitely to talk about if you anticipate you might be boarding any of these kids. If you have to do kind of vital signs monitoring, having your PALS card up so you can put in the monitoring or like the appropriate parameters for your monitor so that your alarms aren't always going off, but you're not inappropriately seeing that something's normal. So for example, if you left your monitors on adult parameters and the infant is now breathing 15 times a minute, it won't alarm, but that should be an alarm bell, because if you have an infant that's now breathing 15 times a minute, to me, that is respiratory failure heading towards cardiopulmonary arrest. If you have to intubate these kids, these bronchiolitis intubations are very high risk, because if a kid's going into an intubation hypoxic, there's a high chance that they'll get more hypoxic or could even arrest during your intubation. So these are some safe practices to help. So under 3 months, ketamine is not safe. So it's usually etomidate or fentanyl for your sedative. We always use atropine under 12 months for our infant intubations, just because if you get hypoxic, you're going to get bradycardic and you might arrest. Atropine can help with that, although the evidence is not of great quality. The biggest thing is adequate pre-oxygenation and strongly considering apneic oxygenation, so having them on oxygen during the intubation. What we like doing at Children's actually is keeping them on the high flow through their entire intubation, so that you have this huge blast of oxygen going in during your intubation and they're less likely to get hypoxic. Positioning, what you really want to do is just make sure that they're positioned where their ears lining up with their sternum. So this is a great example. You always hear this, like, put a shoulder roll under them, and it looks great for this kid. In some babies, just note, if you put too big of a shoulder roll, it actually makes things worse for you and messes up your positioning. So what you mostly just want is you want to position the baby so their ear and sternum are lined up together for your best intubating conditions. Limit your attempts to 45 seconds. Again, kids don't have reserve. So if you're taking longer than 45 seconds to intubate, they are going to get hypoxic and they might arrest. So if it takes too long, you can't get it. You can just have a policy with your team, like, hey, we're going to set a 45-second timer. If you haven't got this in 45 seconds, we're going to stop. We're going to bag them until their oxygen comes back up, and we'll reattempt. And then I always like making sure I have a supraglottic device as backup in case you don't get that tube, and making sure that you have your bag valve mask also if you don't get the tube and you need to ventilate them. Because if you don't get the tube, again, you're going to have a short amount of time in order to start getting their oxygen up to prevent an arrest. For something, if you don't do it frequently, having a checklist for peds intubation, something like this is amazing. This is Cincinnati's, and I'll link it at the end. But if pediatric intubation isn't something your center does a lot, it's great just to have a checklist so you can do it safely if you have time for it. Last thing I'm just going to say about this case is, most of the time, if a kid is pouring snot and in respiratory distress, it's bronchiolitis. But respiratory distress and failure is the final stop of many pediatric illnesses. Like, this is how kids express that they're sick. So if they're hypoglycemic, they will look like they're in respiratory distress or failure. They'll be grunting. They will not be interactive. It's the same with sepsis. It's the same with abusive head trauma, like undiagnosed cardiac defects, electrolyte problems, ingestion, like Kirk talked about. Unfortunately, babies are going to show up looking the exact same with all of these. So if it's clearly bronchiolitis, like they're pouring snot, they're wheezing everywhere, great. But if something doesn't fit, think about what else can be going on. And I think the biggest thing for me here is hypoglycemia, because often it can be one of these plus hypoglycemia. Like, it'll be bronchiolitis plus they haven't had anything to eat or drink in 24 hours. Just check a glucose if the kid is not responding like you think they should. So how can you make a difference with these kids? So use the pediatric assessment triangle to recognize the sick infant in your waiting room. So if they are grunting, that is a 5-alarm fire. Get them back to a room. If anything is off with their appearance, that is respiratory failure. You have a short period of time before that kid arrests. Get them back to a room. If you rapidly correct your hypoxia with suctioning and oxygen, you can completely turn this kid around. think about glucose or other things if the kid isn't responding as you expect. Another nice thing is if they have a fever and bronchiolitis and they look good, in the past, if they were like 28 to 60 days, it would be like, oh, we do LP, we have to do full blood work. In a well-appearing infant with fever and bronchiolitis, most children's hospitals are now seeing you don't even need to do labs. So that's a consideration for the well-appearing infant with bronchiolitis. Consider discharge criteria. So a lot of these kids, if they have bronchiolitis, they're breathing 50 times a minute, but they're happy, playful, reaching for a bottle and not hypoxic. Their work of breathing is not off or like only slightly off. Their appearance is normal, their circulation's normal. They could probably go home. And if you're ever on the fence about it, just call your children's hospital. We get a lot of calls to our transfer center saying like, hey, this is what this kid looks like. Do you think they can go home? And we're always happy to answer those calls. So case 2 is another difficulty breathing. So you have a 6-year-old that walks into triage with his mom and looks like this. He has a history of asthma. So his airway's patent, no stridor, and he's talking with you. He'll like smile and speak in like 3 to 4 word sentences on room air. You're breathing, you see it kind of as it is. So he is working. He's got retractions, subcostal and intercostal, and his extremities are warm and well perfused. And when you get vitals on him, his respiratory rate's 44 and his sat is 92%. And he's tight and has end expiratory wheezing. So this kid, are they in respiratory distress or respiratory failure? So for me, their like work of breathing is absolutely off. So he definitely is in at least respiratory distress, but he's trying to talk with you. He's smiling. I would put this kid as saying his appearance is normal. So he's only in respiratory distress, not failure. So if you're not seeing every single room as a kid with asthma, what you should have for your ED ideally as a way to standardize is this kid's asthma mild, moderate, or severe. There's like, who knows how many asthma scoring systems. This is an example of one. This is the asthma clinical score, but there's multiple. There's the Peds asthma score. There's several other ones. They all work well. Just decide what works for your hospital or what your local children's hospital uses. So for this kid, if we score him, so let's see, tachypnea, if he's breathing 44 times a minute, he scores a 1. His oxygen requirement, is it greater than equal to 92? Yes, so he's a 0. Wheezing, he's got expiratory wheeze throughout, so he's a 2. Air movement, he's kind of tight, so that's a 2. And then retractions, he's got, if you look at him, he's both got subcostal and intercostal retraction, so he's a 2. So his total asthma score would be 7. And that kind of fits with your clinical picture. Like when you look at this kid, I'm like, okay, that kid is in moderate distress, but the asthma score is just a really nice way to standardize that. So then if you have an asthma score, what you can do is use that to inform what your treatment is. And for example, this kid, they're moderate. He's an asthma score of 7. So the plan is starting in triage, start them on duonebs, times 3, so basically getting an hour of this and an oral steroid, and then observe him for an hour and reassess an hour later. If he were in less distress, you can just use the albuterol inhaler with a spacer and a steroid. And if you were in more severe distress, what you can do is work on the positioning of the bed, get him back to a room immediately, and consider starting magnesium, consider starting BiPAP, consider giving epi. So just the score is a really nice way of standardizing it, especially if you're not seeing these kids frequently. So it's great to say like, okay, we're going to give him duoneb aerosols and a steroid. How do you do that? So this kid that you saw in the video was actually pretty calm, but for your 4-year-old kid with asthma who's freaking out, how do you do the things you need to do? How do you get vitals and how do you give him medicine? So the comfort positioning is really helpful here. So the big one, so sitting on the bed. So if you have the parent holding the kid on their lap, or on that photo on the left here, where you basically have the kid sitting on their parent's lap for any procedures, is going to be super helpful for aerosols. So often what we'll do for a kid who's freaking out is just have mom or dad sit on the stretcher and kind of hold their kid in a cross arm grip. And that will let you start your breathing treatments and can allow you to start getting the kid ready for an IV if you need it. The analgesia anxiolysis, it isn't kind of relevant to this kid with asthma, but if you have a kid with a broken arm, no amount of distraction is going to help you calm them. They're going to need potentially intranasal pain medications like intranasal fentanyl, and then they're going to be much more redirectable. So if you need to do something for analgesia, absolutely do it. But most of the time, some upright positioning with the parent holding them in a hug and some distraction. So blowing into a fan, blowing bubbles, videos can be super helpful. And if they're kind of an apprehensive school age child, a lot of the time, if you give age appropriate explanations, it can be very helpful. For meds, how we give them, a mistake that I've definitely seen before is giving the aerosols. The best way to give it is A on the left, so giving it via the full face mask. Doing the blow-by is not effective at all. It's mostly going to get on their face and they're not actually going to have any of it delivered. If you are using an albuterol like inhaler, absolutely always give it with the spacer or it's not going to be effective. The same as with adults. I discharge all my adults with spacers too. It just makes sure that the medicine is getting where it needs to go. For steroids, even for kids in pretty significant respiratory distress, you can still give them their steroids orally. There's no difference in effectiveness like orally, intramuscularly, IV. So usually we'll say if you're doing Decadron or prednisolone, just mix it into a very small volume of something like juice, cherry syrup, something to make it a little bit less terrible tasting and get it in as soon as possible. So don't wait until they're like 30 minutes into their breathing treatments to do the steroids. Do it as soon as possible. So generally we'll do if they're like, if at all you think they will open their mouth, get it in as an oral steroid, otherwise do it intramuscularly. And if a kid is overall like not super ill appearing, a popsicle can be a great reward for that. So this kid, what do you do next? So we're repeating our asthma clinical score at 1 hour. And say this kid, when you listen to him again, he still has end expiratory wheezes, but he's satting 92% and he doesn't have retractions. His asthma clinical score is less than or equal to 2. He can go home. What I like about this pathway, and there's other pathways that you can choose to use, is you can discharge a kid who is not perfect. So you can have an asthma clinical score of 2 and still be very safe to be discharged home with steroids. So again, looking back at the asthma clinical score, like say they have, for example, a little bit of end expiratory wheeze and they have one type of retraction. If everything else is normal, they can still go home unless they have an oxygen requirement and that's why they're scoring. But otherwise, they can be completely safe to be discharged home with steroids. So any of your good asthma clinical protocols are going to have what to do with your reassessment. If this kid were critically ill, the things you can do prior to transfer, start an IV or IO and get in some magnesium and fluids. Do continuous albuterol. Set this kid up on BiPAP if you have a mask that will fit their face. If you don't, then that's maybe not an option for you. Ketamine, you can do ketamine for like a 0.5 milligram per kilo ketamine bolus to help with bronchodilation and also anxiolysis and calming. IMEPI is also a useful tool in the crashing asthmatic patient. And then terbutaline, aminophylline are when you really like throwing the whole kitchen sink at them, but that can potentially be an option if the kid is almost dying in front of you. So for these kids with asthma, how can you make a difference? For the sick patients, early escalation. So get them back to a room, get them on continuous duonebs, give them a steroid, give them BiPAP or IMEPI if they need it. Early steroids for everyone. So the best thing you can do is start steroids in triage, even for the kids with mild asthma, because it decreases their severity, decreases the number of kids who need admitted, decreases ED stay, decreases PICU admissions. Like early steroids are huge for improving outcomes for these kids. Observation and potential discharge. If you like, a lot of our transfers that we get for asthma are kids we discharge kind of as soon as they get to children's. So it's something where if you are able and can safely observe and potentially discharge after an hour or two of observing at your hospital, you save this family a whole extra ED visit, potentially a transport. And that's something where if you're on the fence about it, absolutely like call your referral line and we're happy to talk with you about it. And if you are discharging a kid home, make sure you're always sending them with steroids. So depending, your hospital will likely either do Decadron or Orapred. And if it's the Orapred, it's 4 days. And if it's the Decadron, they get one more dose for home. And then the big thing for them is always primary care follow-up, because their primary care doctor might need to start them on a daily controller inhaler. They may need to do some more education about asthma triggers in the home. So making sure families can do that is huge. And again, if say the kid looks okay, but you have significant social concerns, you're like, I don't know if this family is going to pick up their prednisone, like anything along those lines. So that's something where potentially if you have a social worker that they can help, or if you want this kid transferred to children's because you are just worried that potentially the home situation is unsafe, we are absolutely happy to see these kids. And the last thing I wanted to say about asthma, the biggest pitfall that we run into, and I've seen within the past week, is that you see a kid and they're not wheezing, and they get triaged to a lower level because you don't hear any wheezing when you listen. But when you look at the kid and you listen, what you realize is they are not moving air at all. Those are the kids who are really scary. It was at Children's, we had a toddler who was breathing about, it was like 50 times a minute. He was retracting. He looked scared. He looked like he was staring off into space. But when you listen to him, he wasn't wheezing, and it was because he was not moving air at all. And one of our like PEM doctors who's been practicing since the 90s, like took one look at him when she was put in fast track and like rolled him over to the critical care bay. But the kids are easy to miss. And that kid, once he was put on continuous duonebs, that's when his airways actually opened up and he started wheezing. He wasn't moving enough air to even wheeze beforehand. So that's a big thing, especially the teenagers and the toddlers. It can be easy to miss when they're severely ill, where they're just not moving air at all. So last case is another noise you're going to hear a lot of this winter. I know that's kind of quiet. I'll just play it one more time. So you have a kid up in triage, mom runs in with their 2-year-old, and this kid sounds like a seal and has both inspiratory and expiratory stridor. And the story is he was sleeping and then he just woke up and started making this noise. So 99 times out of 100, it is croup. It's the music of the night. It is the next 4 months of our lives. That is most likely what it is, especially when you get a classic story, like they were asleep and they just woke up and now they have this stridor or barky cough, just based on kind of the hormonal variations throughout the day in cortisol. The morning is when the kids mostly come in with group exacerbations. But the big thing for me is thinking about, just always think and make sure, like, what if this isn't croup? So I think things that we do see that are not croup. So laryngotracheal malacia. So that's it's almost always in young, like infants, so under the age of 1, where they just have kind of malformed and floppy airways. So either in their larynx or trachea, or also even further down to their bronchi. And basically what will happen is the parents will be like, oh yeah, they've always been noisy breathers. And it's especially worse when they lay flat, because that's when all their airways collapse down. Sometimes if they're like, oh yeah, they've always been a noisy breather since they were a baby, but now it's a little bit worse when they have this cold, it may actually be an airway malformation that's been going on for a while. Anaphylaxis can also cause stridor. So this is, if a kid shows up in the middle of the day and has stridor and also has hives, definitely you're like, do I need to reach for my epinephrine now? Foreign body, something we always ask about, even if it seems like straightforward croup, like, do they put things in their mouth? Were they left alone with an older sibling who could have given them something? I always try and just convince myself before I diagnose someone with croup that they didn't swallow something. Retropharyngeal abscesses or upper airway masses can also cause obstruction that causes stridor. Same with epiglottitis or infection of the epiglottis or infection of the trachea. And then the last thing is often you can see croup in combination with things. So like asthma plus croup, we will see frequently, and we're like, it's and bronchiolitis and croup, we'll just call it like bronchiope. Like people have combinations of all of these things. So sometimes you'll have more than one thing at the same time. So for your treatment of croup, you want them in position of comfort. So usually a parent keeping them calm. Give a dose of your Decadron. So again, this works the same no matter how you give it. Almost all the time you can get away with giving the IV form orally. But if the kid will not let you do it, IM is completely fine. And then for the kids who have stridor at rest, they need racemic epinephrine. And if you don't have racemic epinephrine, you can always use nebulized code epi, just like the 5 milliliters of it can work in a pinch. And that starts working in about 5 minutes and lasts 2 hours. And what that does is when you're giving them that nebulized epinephrine, the epinephrine shrinks all of that it's a vasoconstrictor in their upper airway. So it's going to shrink all that inflammation and swelling down and pretty immediately open up their upper airway and decrease your stridor and improve their breathing. I feel like stridor at rest, like the definition of that's always kind of controversial. For me, it's like if I can hear their stridor from the end of the bed and they're calm, I count it as stridor at rest. If it's something where I have to like put my ear up to their face to hear stridor, I don't count it, but you'll see some variability there. And it doesn't count if they're crying or agitated. So if they don't have stridor at rest, if they only have stridor when they're crying, all they need is a steroid and they can go home. You usually don't even need an observation period. If you do give them racemic epinephrine, because it lasts 2 hours, you need to watch them for 2 hours and make sure that stridor at rest doesn't come back. Because if that stridor at rest comes back, they should probably at that point be transferred to a children's hospital for consideration of admission. And then testing, x-rays really aren't necessary. If we can avoid them, that's great. Last couple things. So some of the equipment I mentioned, if you don't use it frequently, it can be really expensive to get the nasal aspirators, the LMAs, the high flow nasal cannulas. Depending on your state, some of the EMSC programs may have resources for cost sharing where you can join together with other EDs that don't frequently see children and buy a box of LMAs or high flow nasal cannulas together to share resources. Other resources that we'll send out after this are some of the ones that I mentioned. So Children's Hospital of Philadelphia and Colorado both put all of their pathways for like bronchiolitis, pneumonia, croup online. So you can use theirs if your local children's hospital does not share, like either doesn't share pathways with you or does not have publicly facing pathways. The PEM Cincinnati link has the link to a bunch of pediatric critical illness protocols, but also the checklist for intubation. The link, the QR code on the right is the Nationwide Children's Sim Center, has videos on administering nebulized meds, bag valve masking children, hooking them up to high flow nasal cannula. So a lot of the tips and tricks that I talked about, but they go through each of the devices individually. And then the last one down here was the respiratory distress playlist from Open Pediatrics. Like if you want to do a pediatric education evening, those videos are fantastic for going through how do you do a respiratory assessment? How do you recognize respiratory distress and failure? And the QR code on the left here, the Peds procedure videos, this is from Colorado. They have like the suction video is one of the ones I showed, but they have about 10 different videos for Peds procedures. They're really fantastic. And I would highly recommend them. And on the right are some resources for if you want to do pediatric sims in your ED. There's a couple of different resources from ACEP and from the academic EM residencies that have already built low fidelity PED simulations you can do in your ED. So I am just about done, and thank you all for your attention. But the main takeaways from this presentation for me is that PEDS respiratory distress can be very subtle. Please do a full set of vital signs in your PEDS assessment, assessment triangle in triage. The Peds assessment triangle is really going to help you pick out which kids are sick. And then when you figure out which kids are sick, it's going to help you say, why are they sick? If the kid is in respiratory failure, you have a very short amount of time to reverse it before they go into cardiac arrest. And your early interventions for bronchiolitis, asthma, and croup make a huge difference. Other things you can do, if that's something you're looking forward to, would be standardizing the pathways for your ED using publicly available resources. And when in doubt, your children's hospital is always a resource. Whoever is there taking calls for the transfer center is going to be happy to answer your questions to help take care of kids. So thank you all, and happy to answer any questions or let you get on with your evening. So thank you.
All right, thank you, Doc. We do have a couple of questions. Let me see. How common is it to see rhinovirus having a major effect on a 3-year-old's O2?
Oh, a ton. So rhinoenterovirus was one of the biggest ones in last year's triple-demic respiratory surge. We don't often do like a full viral panel on all of the kids since it costs like $1,000, but so many of our kids going to the PICU, even the older kids, like 3, 8, like toddlers, teenagers, whatever, if they have rhinoenterovirus, it can definitely cause a viral pneumonia, they can have significant hypoxia, significant bronchospasm requiring albuterol or duoneb. So that was like one of the biggest culprits of last year's respiratory surge.
Okay, we have a request. If you could show the previous slide with the QR code again. And while you're pulling that up, we have another question. Is there a chance of an asthma attack becoming worse again if they are sent home with a score of 2?
Yes, there is always that risk, but it has, at least our pathway and most of the pathways say if you're 2 or under, you are safe to go home. But that's where you get into the importance of really good return precautions and really making sure the family knows how to use their albuterol with spacer, has a plan to make sure they're not running out of their meds, make sure they have a plan to pick up their prednisone, and they have a plan for primary care follow-up. But basically all of the clinical scores say you don't need to be at a 0 to go home. Obviously, if your 2 is that you're requiring oxygen, that's a 2 that can't go home. But any other 2, depending on your protocol, should be safe. Some of the kids I'm a little bit on the fence about, like, for example, if it's the middle of the night or they live pretty rurally, some of those kids I'll just watch a little bit longer. Like technically you only have to watch them for 45 minutes or an hour and be like, you're a 2, you're fine, go home. But if I'm on the fence about them, I'll watch them a little bit longer and see if they declare themselves one way or another.
Awesome, thank you. It looks like those are all the questions we have at this point. And just a reminder to all the attendees, we will be sending out the slideshows and resources in a post-symposium packet.
Awesome, thank you all.